We'll now proceed with our public comment session. And let me begin by saying we welcome and thank the public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For the speakers, we have very limited time for the public comment period. And in order to make it through all of the listed speakers, it is extremely important that each speaker limits his or her comments to 3 minutes. We will display a timer that will cycle through colors as you go through. If you exceed your time, let me begin this. At the end of your time, you will hear me say, "Thank you for your comment, your time has expired." If you exceed your time by 15 seconds, I will state, as a courtesy to other speakers, we ask that you conclude your comment. And if you continue to 30 seconds past your allotted time, I will state your comment time has ended, thank you, and your microphone will be cut. So we will go forward. Again, thank you very much for your comments. And our first speaker is, one moment while I pull up my list. It's Ms. Corgan, please. Ms. Cogan? Corgan, excuse me. C-O-R-G-A-N. Ms. Corgan, please. Please also state your affiliation.
Hello, my name is Susie Olson-Corgan. Thank you for the opportunity to speak today. Today, as I listened to the committee discuss the cases of myocarditis and pericarditis following COVID-19 vaccinations in adolescents and young adults, I was alarmed. As we all know and has been documented, adolescents and young adults have zero relative risk of dying from COVID-19 infection and very low risk of having severe adverse events. But as we have heard today and have seen from the vaccine adverse event reporting system, there have been several severe adverse events reported after receiving COVID-19 injections. As of June 11th, looking at myocarditis and pericarditis alone, there have been 197 reports in 30 to 39-year-olds, 392 reports in 19 to 29-year-olds, and 279 reports in 18 years and younger. Looking at the Harvard Pilgrim study, which states that less than 1% of adverse events were reported to VAERS, it is reasonable to assume that these numbers are much higher than are being reported. From the meeting here today, we heard that there have been more than 1,200 cases of myocarditis or pericarditis, mostly in people under 30. The numbers are growing quickly. This should ring the alarm for all of you. It certainly does for me. With information on myocarditis and pericarditis being just 2 of the SAEs being reported and no long-term safety data on these vaccines, how can you, the ACIP committee, whom are entrusted by the citizens of this country to provide the safest recommendations, continue to recommend any COVID-19 vaccines for adolescents or young adult populations? Furthermore, since we know that many of the deaths stated to be caused by COVID-19 infection in adolescents and young adults have underlying health conditions such as obesity and diabetes, why aren't we talking about how to live a healthy lifestyle? Simple guidance on eating a diversified whole foods diet, getting outside, and exercising regularly. How much could we reduce negative outcomes in the entire population with just these few simple recommendations? A report came out several months ago saying that 90% of COVID-19 deaths could have been prevented if the individual had adequate levels of vitamin D. Why is this not being discussed further? Why is a vaccine the only option being given when we do not yet know the long-term effects are going to be on our children? Why aren't you, our public health regulatory agency, looking at other options that carry zero risk for most individuals? I brought several concerns up to you many months ago prior to the emergency use authorization of any COVID-19 vaccines. I warned you that if this rush through of COVID vaccines continued, that supply of that vaccine would not be our primary issue, but that demand would be. We are seeing that now. Even with the many coercive tactics and incentives given, millions in lotteries, free beer, joints, donuts, scholarships, etc., hesitancy is still growing. The only way that you may begin to regain any confidence from the public is to completely stop administration of the COVID-19 vaccines in the adolescent and young adult populations until the safety studies have been done. Please take these comments into consideration. Thank you for your time.
Thank you for your comments. Next, we'll have Dr. Perry. Let's go to Mr. Houston. I'm sorry, Dr. Perry, I skipped Mr. Houston. Mr. Houston?
Hi there. Yes, can you hear me?
We can. Please go forward.
Thank you. My name is William Houston. I'm associated with Terra Vigilate, a public interest research organization focused on public health and safety. Thank you to the committee for letting me speak today. I just want to start by saying that technical experts with a lot more credentials and knowledge than I were denied a right to speak today, and I was denied the ability to cede my time to this technical expert. So if the ACIP is truly wanting to engage the public and have a robust conversation about the safety and efficacy of these vaccines, I would suggest an additional public comment session that's open to anyone, and it should be take as long as needed to get everybody heard. These COVID-19 vaccine trials must be halted immediately and the emergency use authorization withdrawn because it's causing massive injuries and death. These vaccines are unnecessary for a purported infectious disease with a case fatality rate comparable with the common flu. The EUA was issued using scientific and medical fraud due to violations of the criteria for issuance of authorization, including that the infectious agent is serious. It's not. The benefits of the product must outweigh the risk, and that's highly questionable, and that there's no adequate alternative. Yet existing prophylactics and therapeutics known to be effective against coronavirus infections were banned for off-label use by the FDA. The testing and surveillance program is an unmitigated disaster. All testing, including PCR and antigen and antibody, are non-specific to the SARS-CoV-2 virus, which is purported to be the pathogen which causes COVID-19, yet that simple fact is unproven. RT-PCR is utterly unsuitable for the diagnosis of clinical disease, and that comes from Kary Mullis. He's the guy that won a Nobel Prize for inventing the thing. The FDA recalled 265 test kits, tens of millions due to contamination at a cost of billions. The VAERS database is known to be underreported by a factor of between 10x and 100x. This is according to the Harvard study. There's also what I call the VAERS data lag, and other people are calling it the backloading of data. The CDC is apparently withholding and delaying submitted adverse event reports from the published data by a factor of at least 3x and could be as high as 14x. And when you combine these two factors together, we can say that the number of deaths in the U.S. is not 6,000, but it could be 180,000, and the upper bound might be 6 million. So, this is the 20th year anniversary of 9/11. 3,000 people died. So this vaccine program is like 2 9/11s.
Thank you for your comment.
So far.
Your time has expired.
The rates of these side effects are being called rare. However, we cannot just look at rates of occurrence. The evidence that the numbers of vaccines administered of 300 million, I believe, is exaggerated, which has the effect of lowering the
Our next speaker is Dr. Perry. Dr. Perry, are you ready? Dr. Perry, we'll come back to you. Let me go forward to Mrs. Johnson.
Hello?
Oh, yes.
Hello?
Yes, Dr. Perry?
Can you hear me?
We can. Go ahead.
Okay. My name's Thomas Perry. I'm a retired cardiologist from Phoenix. Thank you for inviting me to speak. My written comment is much more detailed and with references. There is a large sector of the population which does not trust the scientific integrity of the vaccine program. This was especially notable before the mask requirement for fully vaccinated people was removed. I believe in universal vaccination based on scientific proof that vaccines are 20 times stronger than placebo to prevent COVID. No such finding is available for recovered COVID patients. The WHO states that 11 billion vaccines will be needed. Perhaps 2 billion have already been distributed. The CDC continues to target recovered COVID victims who are already immune. If large numbers of vaccine are wasted on the already immune population, the overall vaccine strategy is slowed down, allowing more time for the evolution of variants. Scientific assessment of the durability of COVID immunity is a key to the formation and reformation of vaccination policy. This includes boosters and second-generation vaccine development. The results of 4,837 COVID-recovered victims randomized in the Moderna and J&J trials, phase 3, are pending. The available scientific studies on vaccine durability warrant more critical scrutiny. In my written comment, I examined 4 excellent studies on reinfection of already infected people. These show 180,000 patient years with a reinfection rate of less than 1 per 100 person years, hospitalization rate less than 0.15, and mortality rate of 0. Natural immunity shows itself to be good and durable. By contrast, there are studies which claim that the reinfection rate is high, so that transient immunity should be the working hypothesis. Most commonly, such claims are based on waning IgG levels in neglect of T and B cell immunity, which may be more important. Others omit antibody data using only PCR swab results. A report in Lancet from Denmark uses twisted tables of PCR results to claim only 82% immune protection in the first year of recovery and an extremely low 47% for the 65-year-old and over group. The serious flaws in this study include omission of all data on clinical severity. Vaccine resistors have a sharp eye on the logical and scientific integrity.
Thank you for your comment.
CDC
Your time has expired.
and tend to impugn to
Our next speaker will be Mrs. Johnson Sandal. Mrs. Johnson Sandal? All right, we'll come back. Ms. Berry? Ms. Berry, are you ready?
Hi, can you hear me?
Yes, is this Ms. Berry? Yes. Hey,
Yes, this is Miss Berry.
please go forward.
Thank you. Hello, ACIP. My name is Sarah Berry. I am an independent pro-vaccine advocate from Ohio, and I thank you for the continued transparent and thorough discussions of the safety data. I have previously given comment before about the rampant abuse of autistic children within the anti-vax community and how anti-vax lobbyists in Ohio made efforts to censor my testimony in a government committee. I also wanted to give testimony these past few weeks on Ohio House Bill 248, which would make it illegal for hospitals, nursing homes, and any business or school to require any vaccine, not just the COVID vaccine. However, the testimony protocol was changed, and the anti-vax chair of the Health Committee did not select me to give testimony. So today, I will use this time to give it to you all now. Chairman Lips, Vice Chair Holmes, Ranking Member Liston, and members of the Ohio House Health Committee, thank you for the opportunity to give opponent testimony for House Bill 248. We all saw Sherry Tenpenny come before this committee and turn Ohio into a national embarrassment. Tenpenny is, in fact, one of the founding members of Ohio Advocates for Medical Freedom, who are the anti-vax lobbyists that worked with the sponsor to write the bill. Health Freedom Ohio, the anti-vax lobbyist group that previously tried to censor my testimony in this building, is responsible for the amendments. That makes this bill an anti-vax bill. You cannot continue to hide behind the rhetoric of freedom, as cute as the attempt is. You can call this a freedom bill if you want, but everybody knows it is a freedom to be anti-vax bill. If you have cancer and you want to go to get your normal checkup, you have to worry that the people who are treating you might not be vaccinated against measles. Sherry Tenpenny, in addition, is a grifter who not only is embarrassing for the statements she made in front of this committee, but made statements about mental illness and vaccines and implied that vaccines caused the Sandy Hook shooting. She also, her clinic that she runs in Ohio, offers homeoprophylaxis. Homeoprophylaxis is a non-FDA approved alternative to a vaccine. It is absolutely disgusting to me that these are the experts that you would listen to, and these are the groups that you would listen to in the construction of this bill. I am ashamed to be an Ohioan when I think of the corruption that is going on behind closed doors. I question the testimony protocol changes that have been made, and I urge a no vote on House Bill 248 as it is an anti-vax bill. Thank you for your time, ACIP, and thank you for the time of the Ohio House Health Committee that did not select my testimony. Thank you.
Thank you very much for your comments. Let me go back and see if Mrs. Johnson-Sandal is available. Okay, we're going to go forward then. Ms. Margolin?
Hear me?
Yes, we can. Please go ahead.
Thank you. My name is Kathy Margolin. I'm a nationally licensed acupuncturist and herbalist, and myself, along with my colleagues of East Asian medicine, have suddenly noticed a startling difference in our new patient population. As a small piece of background, I communicate directly with thousands of traditional Chinese medicine practitioners from all over the world in various online meetups, bulletin boards, social, and university groups. We are all experiencing a trend we've never seen before. New patients are arriving with complaints that they attribute to the vaccinations. Some of these pathologies happen within days, others within a few weeks. But the common theme is patients never have these symptoms, and they have all received vaccinations. Acupuncturists like myself are having some very good success with menstrual disorders, Bell's palsy, respiratory issues, palpitations, general malaise, a wide variety of GI disorders, shingles, now more common than ever, and skin and eye disorders, along with extreme anxiety and depression. We can and are treating all of them. But one of the most frightening symptoms acupuncturists worldwide are experiencing with their patients are immediate changes in patients' radial, artery, wrist pulses after vaccination. Pulse analysis is a major assessment of health in TCM. This has never been seen before, certainly not in the volume we are seeing. Clearly, heart mechanics are being affected by these vaccinations. 2 days ago, the World Health Organization revised the recommendations, as you know, for children 18 and younger, no COVID vaccinations for this group. I commend them for this action and would go further to say, pause all vaccinations in the U.S. until the current reports on the Government Bears website are thoroughly investigated, tracked, and reviewed. Pause until we know for sure that vaccinations are safe for all. As a health practitioner, I'm alarmed at what I'm seeing. As a mom, I'm scared for the next generation. I have a pediatric focus in my TCM practice, and this last year, I've seen a colossal amount of depression, anxiety, and suicidal thoughts in the under 18 age group. In fact, for all age groups. China has been treating COVID with herbal formulations since the onset of the epidemic. The acupuncture community in the U.S. has been able to learn these treatment protocols since February 2020. We have learned from some of the very first Chinese medicine doctors in Wuhan what botanical combinations work best for COVID-19 patients. We, the acupuncture community here, have been trained treating COVID patients successfully for more than a year without long-term side effects. We have adapted to virtual consultations and mailing herbal formulas, keeping people out of the hospitals, and now we are being perversely rewarded with patients who have taken the vaccine. I implore you, review the risks of these vaccinations for all ages. Benefits
Thank you for your comment. Your time has expired.
Isn't the rule of medicine and the oath I took, first, do no harm? Thank you.
Thank you very much. Our next speaker is Mrs. Lopke.
Hi, my name is Barbara Lepke. I'm a parent and a parent advocate. After attending the February 2019 ACIP meeting, I've had concerns about the rigor of the ACIP recommendations. My takeaway from that meeting was hearing the phrase numerous times, "Don't let the lack of data keep you from voting." My takeaway from today's meeting is that this will still occur. How can you look people in the eye and say that you voted without all the data? We're told that the mechanism of the cardiac problems isn't known and that there is no data about the long-term effects. We're told that the prior or current COVID infection is being looked at, but the presence of the vaccine spike protein is not. We're told the background rate for myocarditis is being used for 12 to 15-year-olds from 2015 to 2016, but that's 5 to 6-year-old data. Is that year's entire numbers being compared to the vaccine numbers when these kids have only had it for 32 days? In fact, the background rate phrase used in every meeting is very vague. This does not show transparency, nor does it build trust. Why are the different reporting systems using different age group ranges? The discussion is that myo and pericarditis is mostly occurring in young participants, yet the VSD presentation diluted the results by using data from ages up to 39 years. Parents are very concerned about VAERS data. Medical professionals have stated that the forms are time-consuming, cumbersome, and often they are penalized by their healthcare systems for reporting. What are you doing to make sure that all vaccine reactions are being reported? Parents are watching. Parents are relying on you to give the correct info before their children are injured for life. The injuries are not mild to them. Parents feel minimalized. How do you even begin to think you'll be able to address vaccine hesitancy when you do this? The very fact that the ACIP scheduled an emergency meeting to address heart problems and then postponed it to take a holiday speaks volumes. In December, the committee met numerous times on the weekend when the manufacturers wanted approval. An emergency, yet you postponed for 5 days. This brings up 3 possible scenarios. Either you thought it wasn't really an emergency, or you really don't care about children, which I don't think is the case. Or most likely answer, which the public believes, is the outcome was already determined before the meeting was going to be held. Vaccine hesitancy is not about having a needle poke the skin. It's about the lack of trust in you, the ones who are responsible for the recommendations. Will you do the right thing? Thank you for your time.
Thank you for the public comment. Our next speaker is Dr. Moore. Dr. Moore, please.
Hi, can you hear me?
I can. Go forward.
Thank you. My name is Leslie Moore. I am a mother and a physician. I'm not a virologist, but I can read data. And I cannot fathom why this mass vaccination program has not been halted yet, and why the consideration to extend it to younger ages, because the data is atrocious and frightening. First, let's acknowledge that these experimental vaccine products are still investigational, yet there is no comprehensive monitoring and data collection. People get shot up and left to deal with the consequences on their own. All we have is the VAERS system, which is voluntary self-reporting. We know VAERS only captures 1 to 10% of all adverse events. Adverse events are grossly underreported for a variety of reasons. I looked at OpenVAERS this morning. These products have amassed 6,000 deaths and 20,000 hospitalizations in the U.S. alone, which is more than the other 70 vaccines for the last 30 years combined. That is with gross underreporting and a 2-month backlog. Let's face it, these vaccine products are not safe. Now let's consider these products for children. What is the risk-benefit analysis? Children are at a statistically insignificant risk from COVID-19, so there is no benefit to vaccination. And you can't vaccinate them to protect others. These shots don't work that way. They don't prevent infection or transmission. Your shot, at best, protects you from severe symptoms, no one else. Children have no benefit, only risk from these products. Any child injured or killed by the shot likely would have done fine with the virus and received broad and lasting natural immunity. Natural immunity is always better than vaccine immunity. Anyone who says otherwise needs to go back to medical school. Finally, these risks and injuries are all short-term data. We have no long-term data. But one extremely concerning signal is the biodistribution study from Japan that showed that the lipid nanoparticle did not stay in the shoulder as intended, but traveled throughout the body and then concentrated in the ovary. That should set off alarm bells that more study is needed before we inject our youth. In conclusion, I believe available data and common sense justifies a halt to the mass vaccination of our children. Thank you.
Thank you very much for that comment. Our next speaker is Mrs. Dietrich.
Hello.
Hello, go forward, please.
Hello. Thank you. Good afternoon. My name is Christina Dietrich, and I represent Delaware Medical Freedom Alliance. I have 4 children, including 14-year-old twins. I live in a low-income, majority-minority neighborhood in Middletown, Delaware. I also work in home health care. My sole patient for 9 years has a neuromuscular disease and a tracheotomy and is obviously a very high risk for COVID complications. My family therefore took extreme precautions to avoid me bringing the infection to work, including homeschooling. I even made my husband, an Amazon worker, shave his beloved beard. My parents were both hospitalized with COVID in April 2020. The high effectiveness rate of the vaccine seemed very exciting. After the vulnerable people in my life had been vaccinated, I allowed my children back to normal life. As their mom, I decided the socio-emotional benefits clearly outweighed the incredibly low morbidity and mortality from COVID-19 in healthy kids. As I began to consider vaccinating my children, I called the CDC mid-May to inquire about myocarditis and other adverse events. I asked if an emergency ACIP meeting might be called before children 12 to 15 started getting their second doses. Why can we not wait for a BLA? As Dr. Cody Meissner pointed out at the FDA meeting on June 10th, the current COVID pediatric hospitalization rate of 4 per million certainly does not constitute an emergency. Nearly half these children had a positive test that was only incidental to their hospitalization, and 7 in 10 hospitalized for COVID had at least one comorbidity. Your own charter states that you will advise on population groups and/or circumstances in which a vaccine is recommended. Healthy children are not the same as kids with risk factors. I fear that your risk-benefit balance fails to take this into account. I'm also not compelled by the argument that we need to use kids to constrain community spread. It is unconscionable to ask a child to risk his health in order to protect adults. Human beings hold the welfare of our children and the health of future generations paramount. The WHO, UK, Germany, and others have all declined to recommend this vaccine for all children. I thought the USA was the standard bearer for safety and evidence-based medicine. Seroprevalence for COVID-19 antibodies in children is 27%. Why ignore natural immunity? How can universities mandate a vaccine under EUA when the federal government is barred from such a mandate? Would young people be as willing to use this product if they knew, for example, the odds of winning a serious adverse event exceeded the odds of winning a state-run lottery prize? Is it ethical for the CDC director to use out-of-date and improperly contextualized hospitalization data to frighten parents into vaccinating their children? Primum non nocere, first do no harm. In other words, don't just do something, stand there. Recommendations should not be based on conjecture, nor should they be political, made to protect pharmaceutical companies or to manipulate public opinion. Trust in our public health apparatus has declined precipitously. Any risk has been downplayed by government officials with the slogan of safe and effective, which violates the spirit of informed consent, if not the letter of the EUA.
Thank you for your comment. Your time has expired.
Updating your guidance in light of the adverse events in the mRNA vaccines in young Americans will go a long way towards increasing trust in the future. Thank you very much for the opportunity to speak.
Thank you for your comment. Dr. Moore, Dr. Kelly Moore, your next commenter.
Good afternoon.
Afternoon, go for it. Yes, please, go forward.
I'm Dr. Kelly Moore, Deputy Director of the Immunization Action Coalition, IAC, the nation's leading nonprofit focused on supporting frontline immunization providers. Thank you to the committee for your ongoing work, and I want to add my personal thanks to Drs. Ann Schuchat, Nancy Messonnier, and Jose Romero for their years of leadership of CDC and ACIP, especially the past 18 months. With my time, I'd like to recognize another person who's been essential to the work of ACIP. Next week, Dr. Deborah Wexler retires as the founder and executive director of IAC. Although not a voting member of the ACIP, she served on several working groups and has been a constant presence at meetings and the public comment microphone for many years. In the late 1980s, Dr. Wexler first began helping clinicians understand and implement ACIP recommendations. She started out writing a local hepatitis B vaccination newsletter in St. Paul, Minnesota, then went national, creating 3 major print publications: Needle Tips, Vaccinate Adults, and Vaccinate Women, mailed free of charge to the offices of thousands of healthcare providers. In 1993, Deborah founded IAC and created one of the first websites dedicated to immunization, our online home, immunize.org. In 1997, Deborah founded IAC Express, a free weekly e-newsletter featuring the latest CDC immunization news. This morning, the 1,574th edition went out to nearly 53,000 subscribers. 25 years ago, Deborah and her CDC collaborators created Ask the Experts, now an online repository of more than 1,100 up-to-date answers to common questions from immunization providers about how to apply ACIP's recommendations in specific situations. Deborah has inspired many other vaccine champions. In 2005, she conceived of Voices for Vaccines, the first national immunization advocacy group for parents, recruiting and mentoring its leader, Karen Ernst. In 2012, she founded the National Network of Immunization Coalitions to facilitate ongoing collaboration among over 100 state and local immunization coalitions. IAC also is the home of the National Adult and Influenza Immunization Summit, co-chaired by IAC's Dr. L.J. Tan in partnership with CDC and HHS. Thanks to the tireless educational efforts of Dr. Deborah Wexler, the recommendations of the ACIP have been implemented more effectively by thousands of immunization providers, preventing untold suffering. Thank you for the opportunity to acknowledge her vital contributions to the work of the ACIP today on the occasion of her well-earned retirement. Thank you.
Thank you very much. I'm going to go back and see if Mrs. Johnson-Sandal is on the line. Mrs. Johnson, are you muted? We see you on the line.
Hello, can you hear me?
Yes, I can. Yes, we can. Please go ahead.
Okay, thank you very much. I am a mother of 5. I am a grandmother to 8 little ones, and I am very concerned with the adverse events reporting worldwide with these vaccines. They include bleeding, clotting issues, immune system issues, neurological problems, loss of sight, hearing, speech, smell, pregnancy loss, heart inflammation, and the list keeps going on. It is one thing for the ACIP and the NIH and our government to target adults with these vaccines, but to target children when there is such a very low risk of complications with this virus, it makes my heart hurt. It literally, I'm shaking right now. I feel like the ACIP and all the government regulatory agencies are not taking into consideration natural infection, the rates of infection for children, and I would implore this agency to look at this a little bit more carefully, since there are no long-term studies whatsoever with any of this. We have no idea what this is going to look like in a year, what kind of illnesses this is going to create for our children and our next generations. Please, I implore you.
Thank you very much for your comments. That ends our public comment session for today. We will go straight into the next presentation by Dr. Oliver on the overview of data to inform recommendations for additional doses of COVID-19 vaccines. Dr. Oliver.
So good afternoon. For this presentation, we'll give an overview of the data to inform recommendations for booster doses of COVID-19 vaccines. This will include data currently available, as well as data needed before recommendations can be made. Next slide. The main policy question to be addressed is, are booster doses of COVID-19 vaccines needed for those previously vaccinated with a primary series? There are other questions to ask, including, are booster doses needed for all persons or only in specific populations? What is the optimal timing of booster doses after a primary series? And can these be given as a mixed dose, or do they need to be matched to a primary series? Note that decisions around strains for vaccine production are likely to be made separately. Today, we're discussing data to inform the overall decisions around the use for boosters. Next slide. Policy on booster doses will need to be coordinated with FDA for possible amendments to the EUA and ACIP for recommendations around use in specific populations. Both FDA and ACIP will require data on safety, immunogenicity, and public health need. Then before we get into the data, a quick note on terminology. By definition, the term booster dose refers to vaccine doses after a primary series, which could be 1 or 2 doses in the case of COVID vaccines, that are needed to increase immunity after waning of the initial immune response. However, we want to note that if there was a specific subset of individuals who may not have mounted a sufficient immune response after an initial 1 or 2 dose primary series and could need an additional dose to reach protective immunity, this would not meet the technical definition of a booster dose. However, for the purposes of this presentation, we'll refer to them all as booster doses. Next slide. So to inform recommendations on the initial doses of COVID-19 vaccine, ACIP used the ethical framework as well as data on the risk of COVID-19 complications and risk of COVID-19 exposure. Balancing these two risks led to the populations recommended for allocation of initial supplies of COVID vaccines: long-term care facility residents and healthcare personnel, persons 65 years of age and older, persons 16 to 64 with high-risk medical conditions, frontline essential workers, and other essential workers. However, data to inform recommendations for booster doses will require even more information. Next slide. To inform recommendations around booster doses of COVID-19 vaccines, we need to not only have information around the risks of COVID complications and risk of exposure, but also the risk of waning immunity and risk of COVID variants. Next slide. As was done previously, we will very closely monitor COVID-19 epidemiology, including cases, hospitalizations, and deaths by age, setting, and medical condition. Next slide. However, we'll also have to factor in the risk of waning immunity after the primary series. To do that, we'll monitor duration of protection, including antibodies and efficacy after the primary series. We'll also need to assess the ability to boost after additional doses. Next slide. We will also monitor vaccine effectiveness studies and assessment of vaccine breakthrough cases. Data will be monitored again by time since vaccination, age, setting, and medical condition. Next slide. And obviously, any information on correlates of protection would be very important to interpret data around the risk of waning immunity. Next slide. We also need to monitor for risk of COVID variants. We'll need to monitor variant proportions, as well as antibody response and effectiveness for each variant and vaccine. Next slide. So to inform these discussions on booster doses, we can discuss what we know now. Next slide. Booster doses would only apply to those individuals who have already received a primary series. As of June 21st, there have been over 318 million doses of COVID vaccines administered, which means that at least 62% of those 12 years of age and over have received at least one dose, 65% of those 18 years of age and over, and 87% of those 65 years of age and over have received at least one dose. Next slide. For data around immunogenicity and antibody response, first, to discuss what is known around a correlate of protection. A correlate of protection is the immune response that allows prediction of the degree of protection against infection or disease. This work is ongoing and no official correlate has been established yet. We'll review available information on duration of protection, including the kinetics of the antibody response and efficacy from early phase clinical trials. And finally, we'll review preliminary information on antibody responses to variant vaccines. Next slide. While there haven't yet been established correlates of protection, 2 studies have demonstrated robust correlation between vaccine efficacy and mean neutralizing antibody titers across vaccines. In both graphs, vaccine efficacy is shown on the y-axis, and mean neutralizing titer normalized to convalescent sera is shown on the x-axis as a way to standardize across studies. Next slide. The study by Corey et al. Estimated 54 IU per ml as a correlate of protection against detectable SARS-CoV-2 infection, which was estimated to be around 20% of the mean convalescent titers, and noted that the threshold for protection against severe disease may be lower and less likely to be affected by vaccine differences. For variants, where we've noted declines in neutralization titer, they estimate that a 5-fold lower neutralization titer was predicted to reduce efficacy from 95% to 77% in a high efficacy vaccine, or from 70% to 32% for a vaccine that starts out with lower efficacy. Slide. These graphs from the same paper illustrate that initial efficacy may be useful in predicting time until boosting may be needed. For example, a vaccine starting with an initial efficacy of 95% in yellow is expected to maintain 77% efficacy by 250 days or 8 months. But an initial efficacy of 70% in teal may be predicted to drop to 33% efficacy within the same period. However, it's important to note in interpretation of all of this information that this model assumes neutralization is the only major mechanism of protection. These numbers may be an underestimate where neutralization and cell-mediated immunity both play a role in protection. Next slide. Another important consideration is the duration of protection against severe disease. Studies of antibody responses to many vaccines show that after an initial period of rapid exponential decline, antibody levels generally stabilize into a slow linear decline with half-lives of over 10 years. Depending on when this transition occurs, this model predicts that even without immune boosting, a significant proportion of individuals may maintain long-term protection from severe infection by an antigenically similar strain, even though they may become susceptible to mild infection. Next slide. So then what is known around duration of immunity? Antibody persistence has been demonstrated up to 8 months after COVID infection and up to 6 months after the second mRNA vaccine dose so far. 2 studies were conducted around 6 months after receiving the Moderna vaccine. These studies showed lower neutralization titers and higher proportions with undetectable titers against a B.1.351 and P1 variant compared with an ancestral strain. However, many studies have shown larger decreases in variant neutralization for convalescent sera than for post-vaccine sera. Next slide. So as I just mentioned, there was a preliminary data published via preprint evaluating the safety and immunogenicity of a SARS-CoV-2 variant vaccine booster. The two bar graphs on the left are after a 50 microgram booster dose of mRNA 1273 vaccine. The two bar graphs on the right show boost after a B1351 specific booster. On each graph, the yellow bars are sera 6 to 8 months after a 2-dose primary series, but before a third dose. The blue bars are 2 weeks after a third dose. 2 weeks after booster vaccination, titers against the wild-type original strain, the first bar, the D614G on the figure, as well as titers against B1351 and P1 variants, all increased to levels similar to or higher than peak titers after the primary series. Next slide. So overall, both vaccines demonstrated broad antibody boosting across all variants detected. There may be a slight advantage for B1351 highlighted in the box with a B1351 specific boost, but the preliminary study documented that both vaccines demonstrated broad boosting for a variety of variants. Next slide. So we'll also review what we know around vaccine effectiveness, looking at overall real-world vaccine effectiveness in the general population, efficacy and effectiveness against the variants, and effectiveness in specific populations. Next slide. This graph illustrates the vaccine effectiveness from published studies looking at real-world VE in a fully vaccinated adult population. The top part of the figure shows protection against SARS-CoV-2 infection, and the lower graph shows protection against symptomatic disease. Studies looking at symptomatic infection had a range of 82 to 97% vaccine effectiveness, compared to infection, which had greater variation with a range of 65 to 95%. So overall, a higher VE is generally observed for symptomatic disease where assessed. Next slide. So we've shown a version of this slide previously, but this slide shows the fold reduction in antibody titers by variant. Many variants showed reduced antibody neutralization activity relative to the wild type or ancestral strain. The largest fold reductions have been in the B1351 or beta variant, and others are noted here as well. Next slide. So the best way to get specific impact of a vaccine and only a single variant is the lab-based neutralization studies. However, we can look at VE in specific geographic locations and assess what the dominant strain or strains were at the time the study was conducted. You can see that overall VE remains fairly high, even where the dominant strain has been a variant of concern. VE is slightly lower for the B1351 or beta variant, but even for this variant of concern, VE is higher for the prevention of severe disease. Next slide. So we also wanted to highlight what is known around the newest variant of concern, the Delta or B1617.2 variant. The first study is highlighting the Delta-specific VE. For PCR-confirmed infection, one study estimates 79%. VE is higher for symptomatic infection at 88% and 96% for hospitalization. This increase in VE for symptomatic disease and severe disease is what we've seen in both the clinical trials and for other variants. The next section of studies show antibody neutralization studies where 2 doses of a Pfizer vaccine led to somewhere between 1.4 and a 5.8-fold reduction compared to wild-type virus. There was also a recent study from the UK that showed a resurgence driven by a replacement of a B117 with 1617.2, which has a higher transmission rate, and infections were driven by younger unvaccinated people. Next slide. So boosters may be required for a broad population. However, it could also be that the need for boosters of COVID vaccines may only be demonstrated in some populations. Populations to monitor include residents of long-term care facilities, adults 65 years of age and older, healthcare personnel, and immunocompromised persons. And we'll talk through each of these groups in the following slides. Next slide. This figure looks at two-dose mRNA vaccine effectiveness for SARS-CoV-2 infections in older adults and adults in long-term care facilities. VE initially has been high, although with some variability among studies and populations. The range shown here among residents of long-term care facilities was 64 to 92%, and for adults 60 years of age and older, VE ranged from 70 to 95%. Next slide. As healthcare personnel were a group prioritized for initial vaccination, we have several studies evaluating VE specifically in this population. To date, VE has been high for both SARS-CoV-2 infection and symptomatic COVID in this population. Next slide. So next, moving to people with clinically or therapeutically suppressed immunity. The immunocompromised population represents around 2.7% of US adults and includes a broad variation of conditions. We know immunocompromised adults are more likely to get severely ill from COVID and may be at higher risk for prolonged infection, viral evolution, and may be more susceptible to infection from variants. Next slide. This variety of conditions for immunocompromised populations may also impact how they respond to a vaccine. Among populations identified as immunocompromised, there are additional factors that can impact that response, including host factors such as older age, decreased kidney function, and degree of immunocompromise, as well as type of immunosuppressive medications. Next slide. We're beginning to have information around vaccine effectiveness among these immunocompromised populations. One study found that 2 doses of an mRNA vaccine was 71% effective, compared to 90% overall. But as we continue to see, the VE was slightly higher for symptomatic infection. There was also lower protection with increasing age group. Another study estimated 2 doses of mRNA vaccines were 80% effective against SARS-CoV-2 infection among people with inflammatory bowel disease on various immunosuppressive medications. The VE after the first dose was low, highlighting the need to complete the recommended series in this population. And no differences in effectiveness were noted between the 2 mRNA vaccines. Next slide. So this graph shows the percent antibody response after 2 mRNA vaccine doses by different types of immunocompromising conditions. Studies of people with cancer is shown in blue, with hematologic cancers shown in darker blue, which ranged from 45 to 95%, with larger impacts seen among the people with hematologic cancers. Studies of people on dialysis are shown in green and ranged from 45 to 88%. Studies of people with solid organ transplant had the largest defects in antibody response, ranging from 3 to 58%. Studies of people being treated for autoimmune or inflammatory disorders ranged from 40 to 87%. And for reference, healthy controls, which were included in all these studies, ranged from 95 to 100%. And almost all studies that assessed response after the first and second doses demonstrated poor response of people who were immunosuppressed to a single mRNA vaccine dose. Next slide. So in this slide, antibody titers observed in different studies of immunocompromised groups with the same colors used in the previous slide are shown as fold reduction of healthy controls. The largest fold decreases were observed among some of the hematologic cancers, but some studies of people with cancer on hemodialysis with solid organ transplants observed more than a 5-fold reduction in antibody titers compared to healthy controls. Next slide. However, an important question to address is if the situation is in immunocompromised persons would mount a sufficient immune response if given a booster or third dose, if they did not mount one after the first 2 doses. One study in a solid organ transplant recipient who had suboptimal responses to standard vaccination and subsequently received a third dose. Among these individuals, 80% had negative antibody titers and 20% had low positive titers after a primary series. These individuals received a third dose a median of 67 days after their second dose. And after this third dose, over half of those individuals remained antibody negative. Another study assessed persons on hemodialysis vaccinated with up to 3 doses. 83% seroconverted after a second dose, but of those who were negative after the second dose, nearly 60% remained negative after a third dose. As there's no correlate of protection, we don't yet know how these antibody test results relate to clinical protection for disease, so additional studies are needed. We are aware of at least one trial looking at additional doses in transplant recipients. Next slide. So again, while we plan on monitoring data across all populations, these are the populations we've highlighted to monitor closely. First, long-term care facility residents and adults 65 years of age and older. The initial VE is encouraging. However, these individuals were vaccinated in the early phase of COVID vaccine rollout. And in addition, this is a population that in the past has needed special considerations for other vaccines, including additional booster doses or higher dose vaccines. Then for healthcare personnel, they were also vaccinated in the early phase of the COVID vaccine rollout, and they'll also have continued exposure to SARS-CoV-2, even as community transmission rates improve. And finally, for immunocompromised persons, emerging literature is suggesting a reduced antibody response after a primary series. In addition, by definition, this is a population with an impaired immune response. There is concern for the ability of this population, though, to mount an immune response after additional vaccine doses. We will need to consider if this is a population that needs additional vaccine doses or a population that may need other prevention measures, such as monoclonal antibodies. Next slide. And we also wanted to highlight one other note. As highlighted earlier in this talk, that one of the questions will be posed is if what we can call a mix and match, or more formally, a heterologous primary series and booster vaccine. Recent studies from Europe have assessed heterologous primary series with a Pfizer and AstraZeneca vaccine with reassuring results. While we can definitely learn information from these studies, evidence would also be helpful to assess the ability to use different vaccines as a booster than what was used in the primary series, including studies specific to US authorized vaccines. Next slide. So we've discussed what information is already available. Now we want to highlight additional data that may be forthcoming. Next slide. We know we'll have data from the phase 1, 2, and 3 clinical trials. This will include kinetics and duration of the antibody response, as well as efficacy from the early phase clinical trials. In addition, the BLA submissions should include efficacy for approximately 6 months. To inform the heterologous boost, again defined as a primary series followed by a different boost vaccine, there's an NIH-sponsored study that's looking to address this with the results expected late summer 2021. As for booster-specific studies, Moderna has preliminary results published in May that were described earlier in this presentation. Additional data on mRNA 1273 vaccine and other variant vaccines as boosters is expected late summer or early fall of 2021. And data from Pfizer on their BNT162b2 vaccine and variant booster studies is expected from the same timeframe as well. Next slide. So then to highlight data from CDC, we will monitor vaccine breakthrough cases and monitor the severity of disease and genomic sequences, specifically to monitor for variants of concern. We will continue to monitor VE studies over time to stratify by age, time since vaccination, setting, and medical condition. Few things to note. The ability to track waning VE could be impacted by the declining incidence and changes in variant prevalence. In addition, over time, individuals who are vaccinated may become increasingly less comparable to the unvaccinated population, and this will need to be considered in both study design and study interpretation. Next slide. There are many studies ongoing to assess VE and vaccine breakthrough cases, but I wanted to highlight a few here. First, the HEROES Recover cohort. This study is following around 5,000 essential workers with weekly SARS-CoV-2 testing and quarterly serology. To date, they have fully vaccinated populations that have been followed for around 4 months post-vaccination, and they plan to assess neutralizing antibodies at 6 months post-vaccination to inform duration of protection. Then the Vision VE network is a multi-state network of 8 integrated care systems and research centers. They assess COVID disease by confirmed molecular assays and vaccination documented by EHR and registries. The network plans to assess waning effectiveness using a test-negative VE design. Then finally, the IVVE network is a collaboration of hospital-based investigators through 18 tertiary academic medical centers in 16 states. They plan to assess duration of protection by adapting prior methods used for influenza. Again, this isn't a comprehensive list of studies, but highlighting some of the larger studies as a representation of upcoming data that's expected. Next slide. So attempting to put everything together, later this summer and early fall, we expect to receive manufacturer data on safety and immunogenicity of booster doses, longer-term trial follow-up, and results from the mix and match studies. Then early fall, we'll closely monitor COVID epi for any possible increase in cases, COVID variants, VE studies, and assessment of vaccine breakthrough cases. Next slide. So it's worth noting we'll continue to have ACIP meetings where we'll provide updates on all of this data as it becomes available. A vote to recommend boosters in any population could occur whenever data support updating policy. Next slide. This data was reviewed with the work group as well. Their interpretation was that recommendations for booster doses would only occur after evidence of declining protection against illness, such as declines in vaccine effectiveness, not only waning antibody response, and or an escape variant, meaning a variant of concern that is substantially impacting vaccine protection. There's not sufficient data to support recommendations for booster doses currently, but we'll continue to closely monitor. And finally, the work group felt that global vaccine availability should be considered in these discussions as well. Next slide. So the questions we have for ACIP are, what does ACIP feel would be needed to move forward with booster recommendations? And is the risk of disease enough to warrant a recommendation for boosters before additional data may be available? Or would ACIP need to see this data around waning VE and breakthrough cases prior to a recommendation for boosters? Then while you consider these questions, next slide. I again want to acknowledge our amazing CDC team who pulled this data together, as well as individuals on the Vaccine Task Force, Epi Task Force, and Respiratory Virus Branch at CDC. Next slide. I'll also just let people know that the references that were from the studies that were included before are included in the slides that are posted. So you can go back to the questions, and I will turn it over to Dr. Romero. Thank you so much.
As always, Dr. Oliver, thank you for a wonderful presentation. Are there any questions from, or what are the feelings of the ACIP voting members regarding these questions? Not seeing a flurry of hands. We must have entered the afternoon slump. Dr. Talbot, thank you.
Sorry, I was having technical difficulties. So I really appreciate that very well done talk. It really outlined a lot of things. I did want to take a moment, though, and some of this is what I would need to make that decision about boosters, but some of it is about how boosters can become a distraction for us in the U.S. So there are a couple things that I think we really need to talk about. And the first is that we have variants all over the world that occur in places with lots of transmission and low vaccination. And that's not just in countries like India. There are many parts of the U.S. that have incredibly low vaccination rates. So that poses a risk for homegrown variants, but also when variants are introduced for them to spread rapidly through the U.S. And so I think priorities in the U.S. need to be vaccine education. And the first kind of group for that is we really need for families and friends and coworkers and religious attendees to know that they must be vaccinated themselves to protect those that are immunocompromised, those that are frail, those that live in nursing homes. So I think we have a lot to do in the front of education. Two, there are lots of people who still have questions and concerns that we still need to reach out to and vaccinate. So I think prior to going around giving everyone boosters, we really need to improve the overall vaccination rate, because that will improve the protection for those that you have outlined very nicely as continue to be at risk. I think lastly, we really do need to talk about the rest of the world. It's not something that we typically do. ACIP is the U.S. Committee on Immunization Practices. It is not one for the world, but we are now a very small world thanks to air travel and other luxuries. And variants are surging, causing large numbers of deaths across the world. So it is critical to prevent further evolution of these variants by providing vaccines to these countries. And it's not only critical for a selfish reason, it is incredibly important for humane reasons. I know that we have talked about sending doses to the rest of the world, but it's not enough. We need to do more. We have extra vaccine in this country. We need to get it out. We need to stop the suffering that's ongoing, and we need to stop the evolution of more variants. So that's where I stand on boosters, and really appreciate the fantastic presentation. Thank you.
Thank you. Dr. Daly.
Well, first, I want to thank Dr. Talbot for those comments. They're wonderful, and I strongly agree with those comments, and very important. I have a question which I think is probably best directed to Dr. Fink at the FDA, but what is going to be the comprehensive safety database with respect to safety booster doses? Over.
Dr. Fink, are you still on the line, and do you feel comfortable answering at this time?
I am still on the line. So in the past, when FDA has contemplated addition of a booster dose to a vaccine that has been previously authorized for use as a primary series, we have looked at the safety profile of the primary series, including in clinical trials and in post-authorization use. And we have also looked at the safety profile of the booster dose as studied in clinical trials. The overall safety database from clinical trials that has supported approval of a booster dose typically has not been nearly as large as the size of the safety database that we would expect to support initial approval of the primary series for a number of reasons, mainly because we are relying on and leveraging the vast experience that we typically would have with post-authorization use of the primary series. And unless there is a reason to suspect or be concerned about a specific safety concern with an additional dose, then then what we would typically look for is to characterize reactogenicity to the booster dose, and evaluation for much less common adverse reactions would really be outside the realm of what's feasible. So I think for these COVID vaccines, we would need to look carefully at the safety profile from clinical trials as well as post-authorization use. We would need to look carefully at the reactogenicity profile from clinical trials that typically could be characterized with several hundred or slightly more booster dose recipients. And then if there are specific safety concerns that could feasibly be evaluated with somewhat larger safety database, we would take that under consideration as well.
Thank you. Dr. Cott?
So, as someone who takes care of immunocompromised patients, this is a question that I get pretty much all day long and have gotten for months. It's a real challenge because at present we don't, as was nicely highlighted in the talk, we don't really have correlates of protection. We do have people who are checking antibody titers, and unfortunately that really does not signify the level of protection achieved by vaccination. We are seeing different results based on the clinical trials that are going on between cellular immunity and humoral immunity. And so I would encourage us to think about these relatively heterogeneous immunocompromised populations, as was shown in the talk, and to proceed as soon as we have good science on which to base our decisions to proceed with recommendations for boosters or not. But I would wait for the additional data to be available, including the safety data as well. But this is a hot topic. We are seeing somewhat devastating breakthrough infections. I have personally seen people die well after 2 full doses of mRNA vaccine because we believe because they were immunocompromised, it didn't have full protection. So for me, this is the next important frontier that we really need to deal with, and as rapidly as possible. I would also like to second Dr. Talbot's comments about protecting immunocompromised patients by protecting people around them, which is a common theme in the vaccine world. Thank you.
Thank you. Ms. Bata.
Thank you. I really appreciated the discussion about the scope of the issues that are going to be going into this, these considerations. Thank you, Dr. Oliver, for that really great overview. I didn't see the safety profile as one of the considerations for boosters, and I think that was well discussed by Dr. Daly and Dr. Fink. So I'll leave that. And I want to just reiterate something that Dr. Talbot said in regards to the need for outreach to the unvaccinated here in the U.S., the ability for people to have their questions answered, and ways to make sure that we're accessing everyone for that opportunity, both access to information and geographical access. We really need to be focusing on that so that we have less of an issue with variants, both here in the U.S., but also globally as well. Thank you.
Thank you. Dr. Fry.
Thank you, and thank you to the COVID working group for all these wonderful presentations. I would have to agree with the interpretation of the working group in the sense that there's no data to support recommendations for booster doses at this time, except for the caveat of severely immunocompromised hosts who are not able to mount a strong response or no response at all. I think that I would lean towards giving at least one more or a third vaccination using the mRNA vaccines, or a second Janssen, whatever the case may be. And then I also agree that there's no evidence for declining protection against illness at this time at the 6 months or 8 months durability time point, and that right now the variants are not of great concern as far as waning immunity, except maybe the Delta strain. But I think we really, truly do need to wait for more data coming out of these studies that were listed on slide 40 and others like it, including the primary vaccine studies that were done, the efficacy studies. But we also need to wait for some of the information that's coming out of the basic research labs, looking at long-term memory B-cell assay studies and some cell-mediated immunity studies. But that is not to say that we're not to be forward-thinking and really plan ahead so we're prepared to discuss boosters quickly and be able to provide booster vaccines should they be needed. But I would basically agree with the working group's interpretation at this time. Thank you.
Dr. Cohen, would you like to make a comment?
Yeah, Dr. Frey, I just want to go back to the last thing you said. I think you captured the essence of question 2, which I just want to make sure everybody understands. Is the risk of disease enough to warrant a recommendation before additional data may be available? What we're asking there is there what is the ACIP's tolerance for waiting to see disease cases rise and the epidemiology shift, which would then automatically mean that there may be additional cases that were preventable with the booster? So what is sort of this timing and comfort level that ACIP members may have with how much data there needs to be to move forward with the booster, knowing that the more data that we wait for, the potential more preventable cases could occur?
Sure. And that's a tough question to answer, but I'll try to give it a whirl here. So right now, the data looks really good at the 6-month time point. And if we just think about flu vaccine antibody levels decline rapidly, and then by 6 months, you don't have a whole lot. There's nothing really much left. And with these mRNA vaccines, we are seeing very durable antibody responses at this time point. And we don't know what the cutoff is for protection, or what the correlate for protection is with antibody. And we don't know what the true correlates of protection are with other parts of the immune system, for example, T cells, for example, that sort of thing. But so we have to watch very carefully, and I think this is being done by many, many groups, to see if there is starting to be a significant decline in what we do have to measure right now, which is the antibody level, and we can make a correlation with protection somewhat with that antibody level when we look at protection against some of the variants. And so we have to pay attention very carefully to this over time while we are doing these studies and while we are in the basic research labs trying to figure out what the correlates might be and what kinds of things we could measure better. And be prepared to make a recommendation. And you could say, okay, when we reach a certain level, antibody level, which we don't know what it is, but if we could make a template, if you would, if that's what you're asking, and fill in the blanks as we go along before we actually make a recommendation. If you have that template ready, I suppose you could think about that, but I don't know if that's what we really want to do. So I think the only thing we can do at this moment is if we start to see an uptick in reinfections in people or new infections in people who have been vaccinated, that's our clue that we need to move quickly. Now, we can't make a recommendation for a booster vaccine against a variant if there's not a booster vaccine for a variant available. If we can make a recommendation for a booster of the primary vaccines that were given against wild type, because there'll be some of those left over. But we can't make a recommendation for a booster against something that needs to be made de novo, or as a novel variant or novel strain or a novel vaccine if we don't have it available. I don't know if that made sense to you. It makes sense to me. But if you have any more questions, I'll try to answer them.
No, that's great. And other members as well, as we keep going, sort of just to reframe that second question about upticks in cases.
But if we're talking about transplant patients, for example, and Dr. Cotton already spoke to this, and others who are not responding well, I would not be disinclined to give those folks a third vaccination. Again, depending on, as Ms. Spada had mentioned, the safety profile of the vaccine itself, which so far looks good.
Thank you for those comments. And if anybody who already has offered a comment wants to get back on, please raise your hand. Let me go forward with Dr. Long.
Yes, in reference to the things that Dr. Cohen just asked, it would seem to me if we are first talking about a healthy population, maybe people at increased risk because of their age or where they worked, I would think what we were looking for is both very careful look at breakthrough cases and also where there is currently an uptick in the elderly, that would be pretty clear because they are currently so well controlled. I think it would be a mistake to be giving booster doses without both some information about, number one, do they boost? A little bit of safety data, especially since, we have seen the second dose of the mRNA vaccine maybe causing a little trouble, so that we would have some idea that there would be benefit of the booster before we might incur unknown risks. And then I guess I come down a different way a little bit on people who haven't responded to the vaccine, especially that solid organ transplant group. It seems that since the majority of them don't respond to a third dose or a booster dose, that's when funny things begin to happen with vaccines, that maybe things would get worse. Maybe there would be tolerance. Maybe there would be masking of what's left of the immune system to see what's going on. So I would myself not want to give a third dose just because it seems like a good thing to do right now without data. I would try to get some data that it would be of benefit. But in the meantime, I wonder, I don't think it's certainly not on my radar high enough as I see lots of people who have had fallen organs that they know that they're at risk because they're not wearing a mask and they're not maybe doing as much social distancing as they used to. So I think we want to be sure that we have got that message out to providers and patients that just because they're immunized, they may still be at the same risk as if they were not and should be careful. Thank you.
Thank you. And let me make a comment here. The way I look at that second question is similar to the way I look at influenza vaccine. But we have years of experience on the safety and epidemiology of influenza vaccine. But we don't wait until disease is full blown or there's an outbreak fully blown in the United States before beginning a new vaccine with a different combination of vaccine viruses. So I think that as we learn more about what these new variants are bringing, and in particular, for example, what we'll learn from the Delta variant, that will certainly inform us on whether we should begin to consider using a booster ahead of outbreaks throughout the United States or the world to make that decision. So what I'm simply saying is that, yes, we should begin to consider using these boosters before we have evidence of disease from these variants, if this continues to be an ongoing virus with periodic recirculation. So I'll stop there and turn it over to Dr. Lee so that she can ask her question or make her comments.
Thank you so much. In order to answer question number 2, I think I'm starting to break it down in my head according to, what the risk of disease is. So, like, if there is severe breakthrough disease, and we don't have as much information on safety, I think then the benefit-risk balance then pushes me towards, wanting to make sure that we want to mitigate the risk of severe breakthrough disease. I think we've also discussed that of the breakthrough disease, the cases tend to be milder. I guess I would want to know if that in and of itself serves as a boost for those individuals. And then there's the, antibody only. So I guess I would say it's really hard to make any kind of decision without having a good, solid data on correlates of protection. I would feel pretty reluctant in the absence of evidence of breakthrough cases. And then again, the severity of those cases, I think, are relevant. I think this was covered, but just to emphasize that collecting data on individuals who have breakthrough cases, we're collecting the epi. I guess I just wanted to make sure we're also collecting information on the immune response of those individuals at the time of breakthrough infection, and also the variants, obviously, that go with that. So in terms of thinking about the data, part of it is the risk equation, but that also influences the safety side of the equation for me, which is if there are smaller numbers of individuals in booster trials, and we need to also consider that safety data, I would want greater certainty on that safety data if we're talking about boosting before it's clear what the risk data will look like. But as we're seeing if we're seeing severe breakthrough cases, then I think, again, the decision-making balance moves forward, even if there's uncertainty with the safety data. That being said, with the conversation today, of course, that long-term safety follow-up will be important because, for example, individuals who may have a case of myocarditis following dose 2, that question around boosters will be relevant to them. So wanting to make sure that we have information to guide patients in clinical decision-making at that time. Thanks.
Thank you. Dr. Cotton, is your hand a residual from the previous question, or did you want to make more comments? Thank you very much, Dr. Cotton. Good. Dr. Golden has raised his hand. We're now going to open this up to the liaisons also, but just a minute, Dr. Goldman. Dr. Cohn wants to make a comment.
Thanks, everyone. This is incredibly helpful discussion. We really appreciate this and the way that you guys are thinking about this. I want to frame another question for people to consider answering as they're commenting. Similarly to the last question, what do people feel like would be, and you don't have to say now, but you can at least think about it and give us your thoughts about this. Do people feel like there's a threshold or trigger around a VE estimate? So, for example, if in the elderly, if in nursing homes residents, the VE fell to 75% or 65%, what would the threshold of comfortable be to start the booster, and what is the balance of less severe disease versus severe disease in that VE estimate?
Dr. Goldman, your comments, please.
Thank you, sir. And first, Dr. Oliver, as always, great presentation. A few things that came to mind of what I'm experiencing with the patients and what they're coming in and asking for, and if there's going to be any guidance or consideration on antibody testing prior to consideration of booster, if there's going to be any consideration of those with previous infection, which would in some cases almost be like a fourth exposure to the virus and or vaccine. But what is really concerning to me with my patients is the misinformation and statements that are being made out there through the press and others that boosters are absolutely going to be necessary, that things are going to require it of patients. I'm already having patients coming in requesting booster doses. So that's just more information for the committee and the CDC, that when the MMWR comes out and the information goes out to the public, that it really is clarified, the data, the science, and the recommendations. And, for the general public and the news, I would caution that the news media and others do not misinform our patients and tell them to run out and get booster doses already, because clearly those decisions have not even been made and we're still looking at it. So I think those are some important considerations moving forward as far as the education of the public. Before we even consider boosters, we really need to make sure, in echoing some of Dr. Talbot's comments, that we get everyone vaccinated appropriately for the first round. Thank you.
Thank you for your comments. Are there any other liaison members that wish to give a comment or make a statement? I'm not seeing any. I'm now going back to the voting members to see if there's anybody before I close this. All right, I'm not seeing any. So this has been a very good, robust discussion over the day. I think we've given the CDC the information they were looking for. So I thank you all for your participation. I want to remind everybody that we have our second day starting tomorrow at 10 Eastern time with dengue vaccines, and we will run. I'm sorry, Dr. Cohen, did you want to say something? No. And we will have 3 votes tomorrow. One on dengue vaccine, the other influenza vaccines, and rabies vaccines, with a scheduled end of our meeting at 5:15. So, Dr. Cohen.
Thanks, Dr. Romero. I just want to, before we depart, I just want to let everybody know that there were some sessions that were previously scheduled for tomorrow's meeting that are going to be moved to a different meeting date, which we will let everybody know about soon, but it will not be, it will be a scheduled meeting with a regular federal notice, so it will be several weeks away. So we're thinking late August, September. So those sessions will occur prior to the October ACIP meeting, and in addition to any additional COVID meetings between that time.
Thank you for that, Dr. Cohen. So in the absence of a gavel, I will knuckle us to a close. Today's meeting is closed.